Okay, good evening, everyone. My name is Raul Rosenthal, as you can see on your Zoom screen, and welcome to our first roundtable webinar that the ISFGS is hosting together with Dr. Deep, who is the current president of ISFGS. We felt like we wanted to do something different. We wanted to have more a conversation than a presentation. It's late on the East Coast. It's getting late on the West Coast. And people are going to get bored to looking at data and tables and listening always to a same voice. So we're going to have a dialogue. And there are, at this point, close to 50 participants. We limited the participation to 150, and we filled it. So it was very quickly that we got the 150 participants. So probably people are finishing up with dinner or getting started with a drink before they join us. If you have any questions, I'm going to be picking up all those questions and I'm going to ask it to the participants. And if you want to go live, we might even open your microphone if you want to say something nasty to one of the speakers, so you can feel free to do so. So having said that, brief introduction. I think everyone knows Dr. Berber, who is an icon in endocrine surgery at the Cleveland Clinic in Cleveland, Ohio. Fernando Deep, also probably the prime endocrine surgeon we have currently in Argentina, using fluorescent imaging, and current president of ISFGS. And Dr. Michael Beauvais, who is the endocrine surgeon also on the West Coast, UCSD, pioneer in many things with fluorescent image guided surgery, including stealing the idea of creating a fluorescent image guided center from us. So why don't we start with you, Michael? Let me ask you a question. How often does fluorescence image guided surgery is used at UCSD? How often, and who uses it for what?
Oh, that's a great question. Yeah. Well, in my practice, I will do typically 4 or 5 endocrine cases in a day, at least once a week. And I would say I use it probably in 80% of those cases, almost everybody, either for thyroid or parathyroid and adrenal. So I use it all the time in my practice. And then Santiago Horgan, who's a minimally invasive surgeon, uses it on every gallbladder. And Santi and I also do robotic assisted transhiatal esophagectomy, and we use ICG to assess the perfusion of the gastric conduit on all those cases. So, and then the colorectal surgeons are using it for colectomies for low anterior, and the gynecologists are always trying to get the SPI-5 from me to use it for mapping during their GYN cases. And the plastic surgeons are using it for flaps. So I would say it's used every day in the operating room at UCSD.
This is great. Aaron, what's going on at the Mother House in Cleveland?
Yeah, we use it for every thyroid and parathyroid case, adrenals, livers, and also gallbladder. It's especially for endocrine organs because they're so vascular. Fluorescence guided surgery makes a lot of sense. So we use it routinely in all of these cases.
And I guess your plastic surgeons, led by Dr. Pape, have been using it also, correct? For all the flaps?
Yes, other special, definitely. GYN is using for their pelvic lymphatic dissections. Colorectal is using to assess their anastomosis. And also upper GI surgeons are also, by surgeon preference, they also use it to assess their anastomosis on the stomach.
Nice. Fernando, how is it in Argentina, in Buenos Aires? You are in the clinic and in a private and public hospital.
Here is a little bit different because not all the centers have the equipment and also the availability of the ICG. We started to work with this technology for like 10 years ago. And we put together a group of people, you know, my mentor and myself put an Instituto Quirúrgico Argentino del Diagnóstico, center there, and we 100% of the cases use the technology. So every time we operate thyroidectomy or parathyroidectomy, we use or autofluorescence or ICG.
Well, this is great. We can celebrate that finally ICG has been approved in Mexico this week. And I think this is something that we'll see moving faster and faster with the approval of not only the dye, but also surgeons using the equipment. By the way, I don't know, Michael, have you ever had an adverse event with ICG? Have you seen anyone have an adverse event, and what happened?
I haven't seen it. Yesterday, I was going to use it for a parathyroid, and the guy said, well, I had IV contrast and I had breathing problems. And so we said, no, we're not going to use it, So we do ask everybody in the pre-op area, allergy to IV contrast, shellfish allergy, and we just avoid it in all those patients. But so far, I haven't seen any adverse events. Have you?
I personally haven't. Aaron, how about you? You're on mute. You're on mute.
Sorry.
Yeah.
Yeah. We are also using it. We are eliminating the patients who have iodine allergies. And other than those patients, we use it in everybody, and we haven't had any allergic reaction. I think in the literature, it's very rare, like 1 out of 60,000 patients, something like that, I think.
Very rare. Fernando, how about in Argentina?
No, we have done use of technology in gallbladders, in adrenals, in parathyroid glands, and we haven't seen an adverse effect using the ICG. We know that it's reported, and also we don't test the patient. If they don't know if they have any kind of allergy, we don't test the patient. We administrate ICG, and I haven't seen any.
Well, I can tell you at the Cleveland Clinic in Florida, everyone wants to use fluorescent imaging. Even the administration wants to take away our equipment. I don't know for what, but it's widely used by all departments. And we haven't seen any adverse reactions so far. Another important question, I think, for us to share with the group is, do you guys get consent from your patients if you're going to use ICG? Michael?
I don't have them sign a consent. I do mention it to them usually, and actually patients are asking for it. I had a lady come to see me in clinic for thyroid nodule, and she says, do you use near infrared fluorescence imaging for your parathyroids to identify them? And I said, as a matter of fact, I do. And that was not, she had just been reading about it, so patients are asking for it. But I haven't been getting consent, and I thought about it, but it doesn't seem like it's necessary.
I agree. I mean, Aaron, why would you get consent to use a drug that was approved before I was born, 1959?
Yeah, I mean, but what actually, when we did the initial assessment, maybe 10 years ago, we went to the IRB and designed this prospective study looking at various endocrine and hepatic procedures. And we did a number of those patients under that protocol. Once we established the safety and all the data came out, it was part of standard of care. So we don't really get a separate consent for it. It's part of the routine procedure.
Right. Fernando, in Argentina, any?
Same here. We mentioned the patient that we're going to administrate a dye, but we don't consent the patient for this procedure. We consider now as in our practice as a standard of care, talking about thyroidectomy and parathyroidectomies.
Yeah, we don't ask for special consent. The consent reads laparoscopic cholecystectomy with near-infrared fluorescent cholangiography, period, and we move on. So why don't we get a little bit into the world of thyroid and parathyroid? And I want to start. Let's switch a little bit. Fernando, why don't you get started in indications? When do you indicate the use of fluorescent image guided surgery via ICG or autofluorescence when you do your parathyroids, for instance?
Well, now we are so convinced that this technology provides us a lot of information, so much information that we use it as a standard of care. We use it always. And the reason is why, because sometimes we operate the thyroid that is really easy and we find very easily the parathyroid glands, but you never know, it's a surgery. So the equipment is there, we confirm that what we are seeing are the parathyroid glands. And also, you know, we have seen in the publications that that are in PubMed that, you know, with this technology, we can see more glands compared to the white light or with our NAC dyes. And that is why we always use this technology, because we believe that we can see more. And sometimes we are operating a thyroidectomy because of a cancer, and we have to perform a neck dissection, a central neck dissection. So for us, it's a better way to protect the glands. We don't use always ICG to see the perfusion, to evaluate the perfusion. At the beginning, we use autofluorescence. Once we recognize where the glands are and we can protect them, then we evaluate after we perform the thyroidectomy. If we believe that the evaluation of the perfusion is needed, then we administrate ICG.
Dr. Berber, how about you? When do you turn the lights off or keep the lights on?
I've incorporated autofluorescence routinely and ICG fluorescence selectively into our thyroid and parathyroid procedures. And adrenalectomies routinely use ICG fluorescence. For thyroidectomy, as Fernanda mentioned, it increases our ability to identify the parathyroid glands. 20 to 30% of the time, we recognize these glands before we can see them visually. And it's got into so much routine, like if you see a structure that we are not sure whether it's parathyroid or not, instead of biopsying senator frozen, we get this device and then we get a confirmation. Before we send the thyroid to pathology, we'll look at it, make sure there is no retained parathyroids. And our data, I know Fernanda did a great study as well. Our data, even retrospectively or prospectively in a non-randomized fashion, shows that using this device, you decrease your incidental parathyroidectomy rate. And also for parathyroid disease, it also gives us some idea about the function of the gland, where normal glands appear brighter and more homogeneous, whereas hypersecreting glands appear more heterogeneous and darker. So it gives you information that we did not have before.
So just before I go to Michael, let me ask you something, Aaron. Have you checked hormone levels intraoperatively when you take the bright gland out or when you take the one that is not so bright to document that indeed they are hyperfunctioning?
Yes, we do intra-PTH, and if you find multi-gland disease, you repeat the PTH level. So we have confirmation that what we're looking at is whether hyper-secreting or not.
Well, let me give you an anecdote. I'm getting old. When I was at Mount Sinai with Michel Garnier doing the first thyroid and parathyroid endoscopically, you know, fluorescent imaging wasn't even on our radar. So what we thought was a parathyroid, we would take it out and send immediately PTH levels to the lab, and we would be sitting around looking at each other, you know, praying that the levels will go down. But now you see it. Now you know it is. Now what we're doing is probably even a step further to identify which is the hyperfunctioning one and which one is not. There is no question that that is a parathyroid. So Dr. Bouvet, tell us, what do you do, Michael, at UCSD with thyroids and parathyroid? Routine or not routine? ICG or autofluorescence?
Yeah. Well, most of my experience was really with ICG, and I have a good experience with it for parathyroid adenomas and parathyroid surgery. And what I've done was I use it basically on every parathyroid I can when I'm looking for hyperparathyroidism. You administer ICG, we use a low dose, like 1 cc, and about 20 or 30 seconds later, the parathyroid adenoma will take up the ICG and just glow in the dark. And it's really incredible. the pattern of fluorescence is different between the parathyroid and the thyroid. So the parathyroid has sort of a smooth sheet of fluorescence, which you can really see on the black and white mode. The thyroid, on the other hand, you can see the surface vessels of the thyroid gland that light up with ICG, but it has a different fluorescence pattern. So I'm hoping someday we can have actually computer-aided software that will help us even say, yeah, this is parathyroid based on the fluorescence pattern versus thyroid tissue, the way it fluoresces. So that's sort of one of my goals. More recently, I've trialed the autofluorescence, and I love it. It's amazing for looking for normal parathyroids before you even really mobilize the thyroid for your thyroidectomy. And it just tells you where they are. You can, you look at a couple little things that look like pieces of fat and you go, is that parathyroid, normal parathyroid? It takes out the guesswork because you use the autofluorescence, and then you can really be careful around the parathyroid, the normal parathyroids, and preserve them. So I'm kind of sold on autofluorescence now for identifying normal parathyroids.
Wow. So Fernando, are you suggesting, it sounds like, that we're supposed to be using this routinely? Is this going to become standard of care?
I believe it should become a standard of care, because if you have a tool in the OR that is not invasive for the patient, that provides you information, and that it has been demonstrated in the literature that you can see more the parathyroid glands and you can recognize where they are and you can protect them. And also it has demonstrated that decrease the rate of hypocalcemia. I believe it should be a standard, because it guarantee a better outcome for the patients. Of course, we have to disclose that this is a complement to the surgeon. This never will replace the experience of the surgeon, and we need to evaluate and understand the images. But once you start using it, then you want to use it always.
So Aaron, Fernando sounds like he thinks it should be done routinely. We have a problem in the United States if we call this a standard of care, don't we? What's going to happen if someone creates a serious hypoparathyroidism, didn't use it, and they ask you to be an expert reviewer for the plaintiff? Are you going to say to the other surgeon, you should have used near fluorescent imaging?
I think like we need some more data, but I would say like there are some situations. For instance, like if a surgeon removes like a few of the parathyroid glands incidentally, and doesn't look at the specimen with autofluorescence before he sends it out to pathology, I think that is at this age with all this technology, that's kind of really not really good practice. I mean, because if you use the camera, it increases your chances of detecting it. I think maybe that is like clearly, I would say that, the surgeon should have used it. He's really out of date. But we need a little more data about, whether during the dissection he should have used it or not. I think we still need some more data for that. But definitely looking at the specimen before we send it out, it's like it has a significant utility.
So Michael, Aaron is telling us that we need better studies, and you know what's out in the literature, and all three of you are probably the ones who have published the most in the world when it comes to endocrine surgery and fluorescent image guided surgery. What's the study we need, and what are we waiting for doing it? ISFGS is going to host it. Tell us.
Yeah, I mean, well, one thing we have to keep in mind is that really ICG was only used for parathyroids. The first time was 5 years ago. So we are really, this is still early in the experience when you look at the big picture. And autofluorescence, I think, has really only been around maybe 3 years or 4 years at the most. The FDA recently approved 2 devices for autofluorescence. And so now that the technology is there, we do need to develop some prospective trials. I think, well, Fernando can comment on his, but you and Fernando published in the Annals of Surgery a really nice trial showing the benefits of near infrared autofluorescence, I think. And yeah, we really should get together. We need big numbers. The incidence of hypoparathyroidism is temporary is about 20% if you look at all the literature. Permanent is only 1 or 2%. So you have to have enough numbers to really power the studies. It's sort of like using to check for recurrent laryngeal nerve. Have people that use it on every case and swear by it. And if you have a bilateral nerve injury and you didn't use the nerve monitor, I think you could lose in court for sure. Because we know that if you have a nerve injury on one side, you wouldn't go onto the other side. So it may get to that where the lawyers can go after you if you don't have it. Probably not right now, but sometime in the future. So I think we need to lead the way in developing these prospective trials.
So, you know, the problem we had with the gallbladder is the power, because the common Bilac injury is so rare, and the end number you need is humongous. You need 4,000 cases. I don't think that when it comes to thyroidectomies, the number is that rare to see incidental parathyroidectomy, hypoparathyroidism, hypocalcemia. So why don't you guys, if there is anything we're going to take home today, why don't you guys that are 3 leaders in the world, why don't you get together and you know, design a prospective randomized controlled trial with one arm using fluorescent imaging with autofluorescence, the other one without, the one using ICG, the other one without, and bingo. Because I think that, you know, that's what our patients need. There is no doubt that the world needs to turn the lights on, and people are operating in the dark with white light alone. So if they don't do it, our patients are getting hurt, and this is the way to do it. And that trial needs to be done.
You know, Frederick Tripone at Geneva did a trial where they randomized patients to get either fluorescence or no fluorescence, and they found that if you got the fluorescence, and you had at least one gland that lit up, you don't even need to check a calcium level anymore. So there have been a few trials out there that have been randomized that have been very encouraging to support the technology.
Aaron, you promised me you're going to do the trial.
Yeah, but you know, also, but I think that the evidence is really accumulating. Like for instance, if we were to design a study, okay, you know, you're going to have thyroidectomy, and I tell one patient, we're going to randomize you. We might or might not use the device, and he'll definitely tell me, why are you not using it? So I think that at this point, we are beyond the threshold to even go to randomized trials because the data is there. And actually, it was shown in the randomized studies, Fernando showed it, you showed it, Fares Benamud in France, Tripone showed it, that if you use the device, you definitely decrease your incidental parathyroidectomy rate. Ours was about 15%, we dropped it to 6%. And so that by itself is a very quantitative number. I mean, you can't argue with it. Whether it decreases your hypocalcemia is tough to show because you need, as you mentioned, you need really big numbers to look at permanent hypocalcemia, but that is there. So why not use it? So I think that ethically we would have issues in doing that study.
Yeah, the evidence is compelling, but be it as it is, I understand, for me, I'm using fluorescent cholangiogram routinely in my gallbladders. I stopped doing endocrine surgery a while ago. While I practice in Germany, goiter is endemic. So people are walking around with huge goiters because they don't put iodine in their salt. But to be honest with you, not all the surgeons are using it. And to me, it's an ethical issue not to use fluorescent imaging when I'm doing a gallbladder. But having said that, I haven't done it for 30 years, so it could happen another year or two that I can randomize my patients, because although the evidence is compelling, it is not level 1 evidence. And we need level 1 evidence to be compelling. And I think that study needs to be done. Now, let me switch gears. Fernando, how much do you inject ICG and when? when you want to look at the thyroid or when you look at the parathyroid?
No, we use ISG when we want to look at the perfusion of the parathyroid glands. And we usually perform it in case we have a doubt. And in using ICG, we are selective. So not all the patients which have ICG. And the dose that we use, it's really very, very little. It's like 1 or 2 milliliters of ICG. We don't use doses like in other surgical procedures, 3 milliliters or 4 milliliters of ICG, because you know the vessels are so small that it's too much. And the reason why we don't use it with a thyroid in place is because the thyroid captures, you know, takes a lot of ICG. So then it's really very difficult, at least with the equipment that we have, to differentiate between the thyroid and the parathyroid glands. And sometimes the nodes that are there in the middle, right?
Aaron, when do you inject? How much do you inject?
Yeah, for parathyroid identification during thyroidectomies, I do generally 1 to 2 cc's of the solution, which is either 2.5 or 2.5 to 5 milligrams of the ICG. For adrenals, I inject 5 milligrams, and I repeat it a couple of times during the procedure.
Michael?
Yeah, for parathyroids, I just use 1 cc with the device that I have because it's so sensitive. For adrenals, I've been using more like 2 or 3 cc's like Aaron. The other thing that you brought up with adrenals, is kind of nice to see both the vascular anatomy, especially when you're looking for the short right adrenal vein, but also to see the tumor. I did a case last week of a cortisol secreting adenoma, and it just glowed in the dark. And I was going to show you guys a video, but we're not doing videos tonight, so I'll have to save that for another time. But it was amazing how much ICG that took up, the tumor took up. The other thing that you want to do with your adrenalectomy while you're doing the surgery is you want to look at the kidney to make sure you haven't damaged the blood supply to the kidney. And that's the nice thing about ICG. That kidney will glow in the dark if it's well perfused. So that won't happen very often where you damage any blood vessels to the kidney, but it's just one nice thing to give you a little confidence that you haven't injured any of the blood vessels to the kidney.
Any difference, since I have you on the mic, Mike, any difference between primary hyperparathyroidism, a regular parathyroid, or a tumor? How much you use?
Yeah. For primary hyperparathyroidism, well, the parathyroid adenomas take it up very rapidly, and I just use 1 cc. I think that the normal parathyroids also take it up, but they aren't as fluorescent as the parathyroid adenomas in my experience. And sometimes it takes a little longer for them to light up. It could take a minute or 2 even sometimes. So you have to be a little more patient with normal parathyroids when you use ICG. The interesting thing about autofluorescence, which I found, and I'd be interested to find out from Aaron and Fernando, is that with the autofluorescence, the normal parathyroids are extremely bright. But the parathyroid adenomas just have sort of a rim of fluorescence, autofluorescence on the outside, and they don't light up quite as much as the normal parathyroids. But I'd be curious to see if that was your experience too.
So Aaron, tell us how much you inject for primary hyperparathyroidism. Do you make any difference with tumors versus normal parathyroid glands? And do you see the same rim that Michael does when operating on adenomas?
Yeah, I use the same dosage, and then what Michael brought up is actually was very fascinating, because we were using this technology to identify the parathyroids. Then all of a sudden we got this bonus kind of a finding that one of the challenges with parathyroid surgery, actually parathyroid surgery, I think is the most challenging endocrine surgical procedure, because it takes a lot of experience, a lot of mentoring to kind of figure out how to really interpret the parathyroid glands we were looking at. So for a long time, intra-PTH was the only additional tool we had, kind of look at a parathyroid and see if it's really abnormal or not. Now we got another tool. And then this one, as Michael mentioned, normal parathyroids are very bright and very homogeneous, but as the glands become pathologic or hypersecreting, then they become darker and more heterogeneous. Now, like, I almost use this as an additional parameter when I'm assessing the parathyroid glands. And we published about this a couple of years ago. And subsequently, our experience has been the same. This is really a very fascinating finding related to this technology.
Well, we know it from the liver. Ishizawa, Kokudo, and all the group from the Asian Pacific in Japan has shown us how you can differentiate on the uptake of ICG, if this is an adenoma or it's a carcinoma, if it is well differentiated or poorly differentiated. Fernando, primary hyperparathyroidism towards normal glands. Do you see the ring with adenomas?
Well, we identify them with autofluorescence. We don't use too much ICG in order to recognize them. At the beginning, we published in the literature that we could see them a little bit brighter, that the intensity was higher. Then it was like the first 20 cases, and then we started to see that didn't happen. So then we started to see a lot of adenoma that I totally agree with Aaron and with Mike that they glow, the intensity was much lower compared to the normal glands. And also it's different when we change, the position of the adenoma. and if you cut the adenoma, you're going to find different kind of light intensity. I believe what we need, and I totally agree with Mike, is that we need now a tool that really tell us what's the meaning of the intensity that we are seeing. Now it's like more than it's subjective, and it takes time until you start understanding the images. But it's going to happen, and I hope very soon that we're going to have a number, like the CT scan or like PET-TC, that you have a number and you can determine this is benign, this is malignant, this is functional or not.
That's a good point. We have a couple of questions from our attendees, and there is one that I like that pertains to what we're talking about is when you do a total thyroidectomy, can you use 2 doses of ICG? Or will the second dose, change the quality, the intensity of the image? Michael, why don't you start?
Yeah, the answer is yes, you can use a second dose. The thing you have to be careful about is that, a lot of the tissues will just be very, very green, and it may be difficult to interpret things. But and the other thing that's interesting is the parathyroids do retain the ICG for quite a long time. So you'd be surprised. You may give 1 dose and then, check your parathyroids on one side, and then you go to the other side and do your lobectomy on that side. And if you just take your camera and don't give ICG, the parathyroids on the other side may still be retaining that initial dose of ICG. So you can just test the field first before you give a second dose. But you can give multiple doses if you need to, for sure.
Aaron, how about you? What do you think? Do you inject twice? And have you ever tried to inject today and operate tomorrow to see if that parathyroid is still glowing?
That's a good point. For ICG, I haven't done it, but I inject. When I'm doing one side, I inject, and then when I go to the other side, as Michael mentioned, before I inject, I take a look with the ICG mode to see if there's any fluorescence. If there's fluorescence, giving more ICG is going to be confusing. If there's not fluorescence, then you can inject and see the parathyroids on the other side. For livers, I do the injections a couple of days before.
Thank you. Fernando, how about you? Do you inject twice?
No, we inject once, but I totally agree that you can inject twice or 3 times. it's going to be a point that then if you inject more, then everything is going to be glowing. So it does not make sense. And I believe, we need to understand the parathyroid glands like any other organ that has an arterial phase and a venous phase. So, and we need to start also learning this, how the behavior of the tissues and the organs when they are normal and abnormal, that they are totally different.
Thank you. I have another question. This sounds like endocrine master, Dr. Jeffrey Domino. And he's asking what your experience is in how fluorescence image demonstrates subclinical hyperfunction endocrine glands, like the thyroid or the parathyroid. Does it affect intraoperative decisions? Aaron, Michael, Aaron, why don't you start?
Yeah, I mean, I haven't seen that ICG enables me to tell the subtle difference between a abnormal or a normal parathyroid gland in primary hyperparathyroidism, but autofluorescence gives you that information. As the glands start becoming pathologic, they lose their usual autofluorescence appearance, which is very bright and homogeneous, and you'll see that it becomes heterogeneous and they become darker. So you can tell that on autofluorescence, but on ICG you cannot tell it.
Michael, how about you? Do you change your decision with this, and what's your experience?
Oh, I agree with Aaron. I think ICG can be helpful. Full gland disease. I've had at least one or two cases where I was exploring one side, and the cesta maybe said, yeah, maybe it's a little brighter on the right side than the left. So I started on that side, and the cesta maybe just said, oh, it's only one gland. But then when I gave ICG, I saw two parathyroids that were probably 3 times normal size that took up the ICG. And then I thought, I'm dealing either with a double adenoma or I've got 4-gland hyperplasia. So it prompted me to look at the other side, and lo and behold, the patient did have 4-gland hyperplasia and all 4 took up ICG. So in that instance, we did change our clinical decision-making based on the fact that we found, 4-gland hyperplasia, had to do a 4-gland exploration.
Okay, I have 2 more questions here from the head and neck world. One is from Dr. Lisandro Montorfano, who wants to know when it comes to ICG, if it should be injected to localize head and neck sentinel lymph nodes, and how long would it take for you to visualize? And then Dr. Montoya, along those lines, says if you use ICG for localizing lymph nodes with thyroid cancer. Fernando?
No, we use definitely, it's a very good tool to find sentinel lymph nodes in breast cancer, in melanoma. I don't find this technology, at least yet, that is ready to go to in order to identify sentinel lymph node in thyroid cancer. And the reason is because the distribution of the nodes in the neck sometimes you may have different nodes, and the penetration of the light is not so good. So if you have a node that is behind, for example, the muscles, probably you are not going to find that. And this is not what is happening in other parts of the body. If you are going to follow a lymph vessel, for example, looking at the sentinel lymph node in a melanoma, it's different. You are looking behind the skin. But I don't find, at least I haven't read any paper that really supports with a level 1 evidence that this is a very good tool for sentinel lymph node in thyroid cancer.
Aaron Berber, sentinel lymph nodes, subclinical thyroid cancer, yes or no?
No, actually, I was very excited about an expectation that it would actually help when we start using ICG, but we injected around the tumor, we injected intravenously, and there were some false positives and false negatives, so it's not useful.
Mike?
Yeah, the interesting about thyroid cancer is that I'd say at least half the time your lymph nodes are already color coded. It's because of the hemosiderin and the pigment that sort of lines the lymph nodes, but you've got color coded fluorescent without fluorescence with your metastatic papillary thyroid cancer lymph nodes. So you just look and they're black, they're dark, and it helps a lot during neck dissections, in my opinion. So I haven't tried ICG to do a sentinel lymph node yet for thyroid cancer.
So along those lines, while Mike, I have you on the mic, neck dissections, how useful is ICG to look at that thoracic duct when you're doing your neck dissection and you don't want to injure it, number one? And number two, how useful can it be to see the parathyroid glands? Manny Lomenzo is asking, how about nerves? You guys don't want to see the nerves?
Yeah. Well, let me take the nerve question first. We have a clinical trial going on at UCSD right now. The PI is Ryan Orozco, and it's a peptide that was invented by Roger Chen and Quinn Nguyen at UCSD that's tagged with a fluorescein. So we've injected it now into 6 patients with thyroid cancer to identify the recurrent laryngeal nerve and the vagus nerve. And it's just at real low doses, but it's very encouraging, and it's rapid too. It's a peptide, so we inject it in the pre-op area, and then we have special cameras in the OR, and we're color coding the nerves because the probe goes to the nerve. So I think this is going to be something you'll see hear more and more about. It's a multi-center trial. The other centers are Stanford and Harvard. So
and they're looking at the nerves. They're all looking at nerves.
Just looking at nerves, and we're doing it for thyroid, we're doing it for neck dissection, and also for parotidectomy to look at the facial nerve. But you could imagine it could be used for other surgeries where you're worried about nerves, like prostatectomy and so forth. So this is exciting, and there's other groups that are, looking at nerve-specific probes. But this is actually in the clinic. It was approved clinical trial approved. So started about a month ago.
If you ask
in
me,
terms of the thoracic duct, the thoracic duct.
Thoracic duct. Go ahead.
Thoracic duct. I tried it once. It didn't work. But John Fay, Phay at Ohio, published a very nice case report of using ICG. And what he does is he injects it into the web space of the great toe and the second toe, and it gets taken up by the ducts and goes into the chylus cisternae all the way up the thoracic duct. And then when he's doing a left neck dissection, he can see the thoracic duct, and of course that's so to identify that and not injure it, so you don't get a chylus leak after a neck dissection, which can be a disaster. So when I tried it, it didn't work, but that doesn't mean anything. It was my first case. I think I'm going to try it again, see what I can find with it.
I've seen a video for esophagectomy from a group in Brazil.
Yeah.
It's mind-blowing. They do exactly the same thing to identify not only the thoracic duct, but lymph nodes when they do the lymphadenectomy. Dr. Berber, how about looking at the nerves? If you see the parathyroids, you should know what the recurrent laryngeal nerve is, don't you?
Yes, that's true. And interestingly, actually, I found a utility during robotic transaxillary thyroidectomies, because in those cases, I was using to find the parathyroid glands, and I realized, the thyroid and the parathyroid take up the dye, and the nerve doesn't. So in all the green structure, you see this white structure that's not taking up the dye, and it increases your attention to identify the recurrent laryngeal. Just that was serendipitously the way I used it, but I don't have experience with the thoracic duct identification otherwise.
Dr. Deep, thoracic duct and nerves.
Well, thoracic duct, I didn't do that. Didn't perform that procedure in the neck. We do have experience in the abdominal cavity, patient after that had nephrectomies, and they were leaking lymph, and we administered ICG in nodes, and we could identify the leaks, and we clip it, and the problem was resolved. So I believe it's a very good tool. And nerves, I believe it's the future for sure. Yeah.
I would say it's the present. But having said that, let's switch gears. How about teaching, guys? Dr. Berber, do you see any value in using routinely near-infrared fluorescent imaging, be it autofluorescence or probe-mediated, when you do general surgery? Shouldn't the residents be exposed to this?
Yeah, actually, they pick it up because they see it being used during the cases, and I think it increases the amount of learning from a case. Like in every neck case, because of this technology and taking the time to look for the parathyroid glands, they kind of learn how the parathyroid look like and where they're located. And when we're doing adrenal surgery, likewise, they figure out where the dissection planes are and where we should really go. I think it increases the learning experience from the case, and they pick it up. Now it's like ultrasound. It's like we routinely use, and like robotic surgery too, that I think they become very familiar with it.
Fernando, do you use it with your residents? They like it? Is it helpful?
We use this more in the private practice compared to the hospital. We used it in the past in the hospital a lot. It is really very useful. We published a paper with you and when we show and we showed there what happened when we are using the technology with residents and with white light and with near infrared. So we showed in that study that we showed the patient the residents different structures with white light, that we asked them to recognize the structures. And then we evaluated how many structures were recognized with white light, and we did the same with near infrared light, and the curve was statistical significant. So the residents identified quicker, more accurate the structure with near infrared compared to the white light. So I believe it's totally useful.
So Michael, how about teaching near ICG, and how can you teach your administration that this is more important than buying a freaking robot, because this is going to have an impact on our patients, while the robot is going to be, a robot enables a surgeon to finish an operation, while ICG prevents a surgeon from having a complication. So how can you convince your administration to wake up and smell the coffee?
Yeah, well, I think the teaching is great. The residents adapt to new technology, and they're all for it. Really, some of the naysayers are the older surgeons, and they say, "Oh, what do you need that for?" But the residents love it, and they can see the value of it. We just, it's July, so we just had a bunch of new residents come in. We had a new minimally invasive fellow who had never seen ICG for a lap chole. And after the first case, the fellow said, "I'm never ever going to do a lap chole without ICG again." They were just so amazed, and I think seeing is believing. So it's not hard to convince residents about it, the technology. I think it is a little trickier for hospital administrators, where you have to really prove that you're going to make a difference in cutting costs, but really it's all about avoiding complications, like you said. So that's really the important thing about improving outcomes. And I think the administrators do understand that, hopefully anyway.
Aaron, how about at the Cleveland Clinic?
Yeah, I mean, they're more like an outcome and data driven. So we have to present some patient outcome indicator to them. I mean, for adrenals, we tell them, it increases our ability to recognize these structures. And if you're doing a pheochromocytoma surgery, it enables you to really figure out how you can do a cortical preserving adrenalectomy. And likewise for parathyroids, we have data showing that it decreases your incidental parathyroidectomy rate, and also gives you some more feedback about the whether parathyroid you're looking at is pathological or not, and also it decreases the number of frozen's you would do. So we feed them with data, and if they see the data, they see the cost savings and the patient advantages, then they're okay with it.
Fernando.
Well, I totally agree with I totally agree with Mike and with Erin, but what I can add is that something that Erin and Mike said before, patients are going to ask for this. You know, Mike said before or at the beginning that the patient asked if he's going to use, if he was supposed to use ICG for the procedure, and Erin told us that when he was designing the trial, the patient didn't want to be in the arm without ICG. And this happens with everything. When the patient has the information, enough the information and the appropriate information, and you tell the patient the truth, that this is a tool that is going to give you more information. So why they're going to choose, another option? So as soon as the patients start asking for this, I believe the CEOs of the company are going to buy the technology and are going to acquire this, because this makes the procedure safer.
Agreed. Well, one of the things I want to make sure that in future roundtables, our participants know that we are on time. We start on time and we finish on time. We are at the 45 minutes that we promised. We haven't talked too much about the adrenal, but I think we touched upon important issues with adrenal already. Just very, very brief. Erin, do you use it for the adrenal? Yes or no? How much do you inject and when?
I use it routinely. I inject 5 milligrams, which is 2 cc's. When I'm ready to identify the anatomy, in a couple of minutes, the adrenal lights up. And I repeat it about 2 times every case.
Fernando Dip, adrenalectomy, ICG, yes or no?
Same thing, we administrate 3 cc followed by 10 cc of saline, and we redose the patient if needed.
Mike, you mentioned already that you use it and you were stunned by how tumors will take up the ICG. So I assume you use it routinely as well?
Yeah, I do, and I think it's helpful. The normal adrenal also takes up ICG, so if you want to make sure you take the whole gland out, you can really do fluorescence guided surgery. Just keep it on the color overlay mode. Or as Erin mentioned before, if you have somebody with a bilateral pheo and you want to do a cortical sparing adrenalectomy so that the patient's not on steroids for the rest of their lives, you can use the ICG the other way to make sure you leave a little piece of vascularized adrenal in. So yeah, you use it to your advantage for sure.
Thank you. Well, before I close, I'm gonna ask each of you 15, 30 seconds if there is anything you want to say, any questions you want to ask that I didn't. Why don't we start with Mike while I have you on the mic?
I think you were pretty thorough, and I really enjoyed this session. I always learn a lot too, and I think it's like anything else. The more cases you do, the better you get at it, and the more you realize, what the pitfalls are and what the advantages are, and you do have to really make sure that you use everything you can and not rely on one technology, but it's definitely here to stay, and it's helped me a lot in my practice, I think.
Dr. Berber, final comments.
I think this was really a nice roundtable. Thank you very much for moderating it. I would say that like the benefit and the take home from these technologies is different for everybody, and I think like it has to do a lot with your surgical style, and everybody might find one aspect more valuable for himself or herself. So I think you just have to use it and see what you think, how it could fit into your practice. I think it might be wrong to say, oh, you should use it for this, and then I think when you use it, you figure out when you would need it and when you would not need it, and some of the special indications like we've identified in our practice.
Thank you. Fernando?
Well, first of all, thank you very much. I enjoy really very much the session. And my message is that we need to perform or to put together randomized trials to keep having more and more data. I believe this is a complement, a very useful complement, and we need to understand that this guides the surgeon and allows us to see better. And this is like a GPS in the car. So I believe in the future, all the platforms are with the options to have or to use near-infrared light. Some surgeons are going to choose to use it routinely. Others are going to choose it selective. But at least you know that technology is there. If you need it, you have it and you can use it.
Thank you. Well, I think you guys are three phenomenal in not only how you practice endocrine, but also fluorescent image guided endocrine surgery. I thank you for your time, for your experience. I want to encourage all participants that haven't joined our society to do so. You know, believe it or not everything that is good in life you need to pay $1,000 for. Joining our society is for free. We have a wonderful website. Our goal is what you see here. Clinical practice, education, and research. So it's for free. Enjoy it, encourage your students, your residents, your fellows. And last but not least, my take-home message is to all the surgeons, it's time to turn on the light, the near-infrared light.